Good morning, Saudi Babtain Cardiac Center. Dr. Nagy and Dr. Hussein.
Can you hear us?
Yes, we hear you. Good morning. Welcome to CardioEgypt 51st meeting.
Go to the end.
We are waiting Professor Wael Kashkari who will join us soon, and I have with me Professor Hussam Hassan, chairman of the meeting, professor in Asyut University, and Professor Muhammad Satiha, professor of cardiology in Tanta University. And so please introduce yourself and give us a brief about the case. My name is Ahmed Magdi from the Egyptian Board of Cardiology and Egyptian Society of Cardiology.
Thank you very much. Good morning, everybody. Assalamu alaikum for everybody. We would like, first of all, to thank CardioEgypt for inviting us. We would like to thank as well SASIS, the Saudi Intervention Society here. We have a great team with us today, and we have chosen a case that very common practice. We did not choose a very rare case or an exciting case, but I think we have a lot of debate about this case. That will generate a lot of discussion with hopefully very good scientific background as well. My name is Dr. Naji Al-Hulaimi. I'm a consultant interventionist here. I'm one of the old guys here. Our main operator here is Dr. Hussein Zahir, and he's going to debate the strategy later on. And we are privileged today to have Dr. William with us, who is an worldwide expert actually in OCT. He was just visiting by a chance, and we are happy to have him with us today. The rest of my team here, I got Val as our scrub nurse with us, and I got Joanne, and I got Rida, and we got our Medtronic people. We would like to thank Medtronic for supporting the live transmission here. We will go for the case. We have taken a few images, and we will go live with you with the case. I'll discuss the case with you to start with.
Yes, please.
Yes, please. This is the 40. Do you see the slides?
Can you see the angel?
Yes, we see the angel and we see the slides.
Let's see the slide. So this is a 45-year-old Indian gentleman who did have some smoking history. About 3 weeks ago, they came in with an inferior STEMI, which was treated with the primary PCI for an occluded circumflex with 2 drug-eluting sets. And at the same time, we found that he had severe mid-LAD, bifurcating lesion with a diagonal, and a CTO of the mid-RCA. His echo at the time shows that his hip traction was mildly to moderately reduced with an EF of 45%, with no significant valvulopathy at the time. Patient was seen in the clinic and he was doing fine, and accordingly we brought him today for a safety outpatient PCI to the LAD as part of the complete trial population. This is the original angio. That's when he presented with an occluded, as you can see, mid-circ going to an OM. And we cannot appreciate the LAD lesion here, but on the caudal view, you could see that the proximal segment crossing a reasonably moderate diameter, long diameter to support the disease.
Okay, so let me stop for a while and ask the panelists here if this patient is coming with it's typically a multi-vessel disease presenting with acute MI, and so what would be the strategy? So I will let Muhammad Satiha, he will give his comment.
Good morning, Dr. Naji. This is a challenging case. It was I understand this is a case presented with inferior MI 45 minutes ago or another day.
No. He's a 45 years old.
Yes, okay.
He presented with inferior STEMI just a few weeks ago only.
So most of the time with this complex case, first you treated the culprit vessel at the same day of the presentation, and the situation you will do a bifurcation lesion. So it was better to postpone it to maybe at the end of the in the hospital, before hospital discharge, you can do the bifurcation LED diagonal, and maybe later on you can do the after 1 month or within 45 days you can do the right coronary artery. But the first in the index procedure is the ACX, and before hospital discharge you can do the bifurcation. And later on you can do the right coronary artery. Most of that's the guidelines tell us that.
Okay. Sir, would you like to comment? So,
Okay.
what was your plan?
What is challenging today is the type of different visualization that we might have on bifurcation.
Yeah.
Here you have a magnified view in AP cranium that is showing, number one, the diagonal branch that is a longer branch with some very severe osteostenosis, and then some apparently in this view modest lesion on the opposite side involving the LAD. If you are coming back couple of images in the REO, you can appreciate how different the angiographic view can give you the perception of the lesion. Here you have clearly a 111 lesion on the LAD and diagonal. And so this is the focus of today, and I wanted to leave to the team to explain also the strategy.
Yes, correct.
Yeah, I think if we consider two stents from the beginning or provisional, there are some factors, including that this diagram has ostial and proximal. It is extending more than 10 millimeters, the lesion there. The angle is small, I think less than 40. And yeah, there is a tight lesion in the LAD exactly at the origin of the diagram. So, do you like to discuss what is the our strategy or our thinking, and then you tell us what you have done? Again, I will go back to Dr. Satiha. If here is your strategy, what do you suggest? What do you?
I think first in this bifurcation is a complex one, and the angle you have to do imaging first. This is one of the most important for sizing, for degree of calcification, and then I prefer to do maybe DK crash or something, because the diseased diagonal from the ostium is a large, also long vessel, maybe to 2.5, and I think is a two-stent technique from the beginning. Or another option is to do provisional with drug-eluting balloon over the diagonal branch. If there is a pre-dilatation of the diagonal branch, have a good results without a significant dissection. You start with preparing the lesion to see the results of pre-dilatation, and then decide two-stent technique or one-stent technique. I don't know.
Okay, Dr. Nagy.
We'll give the mic to Dr. Hussein, who's our main operator here. But as we said at the beginning, this is Medina 111 very clearly on the, even without going to the intracoronary imaging, which we have done already. Now, in regard to whether this is a complex or a simple bifurcation, it depends how we code really the proximal segment of the diagonal branch. The diagonal branch, eyeballing it here, maybe a 2-0 only. It's a large area of supply to the LV itself, but we will leave it for Hussein to discuss what he thinks, and we are open for suggestion as well.
So thank you everyone for this kind invitation. This was such an insightful discussion. I agree with my colleagues here. This is a significant severe LAD lesion, and as you can appreciate, the diagonal branch, the ostium of the diagonal branch is really diseased. However, you know, angiographically, the size of the diagonal does not appear to be more than 2.5 millimeters. And although the diagonal branch is diffusely diseased, the ostium of the diagonal is the most affected. So I agree with your initial thoughts. We did decide to image with the OCT. So what we did, we went 6 French femoral as his radial was not applicable. So we used the ultrasound access approach to obtain or access. Then we went with a 6 French guiding catheter. We wired both branches and we did OCT of the main vessel. And I will hand it over to Dr. Guaglioni to comment on the OCT.
Super. So number one, use the Ultron system. Here you can see different You can see the angio-co-registration that is crucial. When you are moving, you have the point in this white marker on the angio in the same projection. And then beside, you may see the corresponding cross-sectional view. When you are moving, everything is changing. And
Do you guys see the OCT or no?
No imaging. We saw only the angio.
We only see the angio with the catheter, but not the
Switch our
OCT
camera.
image.
okay, just wait in a second.
Okay.
I think that, but you can derive the signal directly. So there is some problems in deriving the signal. Well, anyway, I was saying while we are waiting to
Do you
get.
see our screen now?
Yeah, partly we see the OCT, partly, from the side. Okay. Yes, now we.
No, not yet.
It appears.
Okay.
Yes, okay.
Sorry for the technical trouble. So you can see the angio-co-registration when I'm moving across the longitudinal view. You can see that the marker, the white marker is moving, is telling you where you are. So just for understanding where you have this white dot in this longitudinal view, you can see that they are branches. Here is the branch.
Yes.
You can see you can see clearly the diagonal, and you can see the plaque.
Yes.
So number one, there is no orange. No orange means no calcium, no significant calcification. Here is a little bit, but is less than 180 degrees. This is immediately before the takeoff of the diagonal branch. So it takes more than 180, the minimum for displaying the calcification. So when you are not seen, it does not mean that there is no calcium, but it means that is limited in the distribution. Now I'm going back to the first part of the LAD, and you can see that here, lumen is becoming bigger. You have clearly the evidence of the 3-layer structure. So the proximal part of the LAD where we have the septal seems to be okay, devoid of significant plaque or lipid plaque. You have some plaque from 7th to noon, but it's not, the lumen is very big. Now we are going to get some information about the measurements. If I'm going back, this is the bifurcation of the distal left main and then going back to the left main. So this is for morphology. Then we are going to sizing, and automatically you have a display all the measurements that you need. When you are moving inside, and I'm going to the bifurcation at this point at the central panel, you can see that the lumen area was very, very minimum. It was 177. You remember that we are targeting a lumen area of 4.5. If there was some doubts about the severity of the lesion, this lesion was very severe. That is the first point. Severe with not too much calcification. Then you can see in the panel below the lumen in black in the longitudinal view, and then you have the tiny line, and the tiny line is the EL detected. So the people wanted to know, how big is this vessel? We are going here, in the central panel, you can see that the EL was a 321. So we can go with a 30 stent that we needed to expand proximally. We tried to search for the distal landing, and we said, okay, this could be a right point for landing distally, and we fix with this marker. Then we went to the proximal part in searching for where to land proximally. And here you have the EL that is going 393. So if we are taking a 30 stent, we needed to have one stent that is at least arriving 375 in terms of lumen. Because remember, the EL is a little bit bigger than the lumen area, and perhaps, so if we can use a 30 stent, and below you have the lengths already defined, 19 millimeter. So perhaps we can go with a 23 millimeter. We already define which are the points to be selected and the type of the plaque. These are the essential information that we derive from OCT.
Okay, so we got very important information from OCT.
We'll decide about the strategy and the route to launch.
So,
But this is very nice view of the OCT, explaining a lot that we haven't seen on the angiograph.
yeah, very good. So, do you?
So let's have another question, please.
If you have IVUS and OCT, you think the OCT had added much more advantages compared to the regular IVUS, which most people do?
I think that you saw a pullback done in 2 seconds,
Yeah.
and how much is rich in terms of information, what you can get by using OCT.
Yeah.
Very precise lumen, detection of the EL in this case, immediate detection of the calcium, and co-registration. Co-registration is phenomenally important because you can see exactly where you are and you can decide what to do. Okay?
Just a small question, Dr. Hussein. If there is a sizing of the vessel, you take exactly for the IVUS comparable to the OCT. What is more precise to take the sizing? Is it we know that the OCT undersizing the vessel a little bit. Angiographically, it looks the vessel 3.5 angiographically. And now you tell it's about 3.2. Do you want to oversize a little bit, or you take also 3 millimeter stent?
I don't want to oversize. Go ahead.
Yeah.
The balloon dilatation.
Yeah, can we get the...
I think you number one, that this story of instead is the opposite, that the IVUS is oversizing compared to the phantom, while OCT is bringing the same measurement. But with the last generation of IVUS, the high resolution, the two technologies are very similar in measurement. So it's exactly the same. In fact, here in the distal part, the EL is 321. You can go also with possibly some bigger, but we know that today we have a stent that can be enlarged. For us, the most important point is not to disrupt the distal edge of the stent, and so try to get the right measurements done at the distal reference point. And then the proximal is going to be post-dilating.
Okay, I think you are aware of the.
So back to the main angio. Can we go back to the main angio? Okay.
You are aware of the October trial that had shown superiority of OCT in bifurcation treatments.
16?
16? I'm on 16.
So now you start with the main vessel, or you start with the, I mean, you will, what is the strategy which you are going
So
to make?
after discussion with our team members, we decided to go with a provisional approach. We're going to treat the main vessel, optimize it, and then reassess the side branch. So we're just pre-dilating here with a 2.0 15 millimeter balloon, we went to 60 atmospheric pressure, and we see that there's no waste, and the region seems to be expanding well.
Okay.
I think we can proceed with stenting. I did.
You did already.
We didn't. We could go ahead and pre-dilate the diagonal. Okay.
So what do you think in terms of panel? Do you think that the diagonal should be dilated first, or you want to then wait and see the vessel? We wanted to get a little bit of discussion on this aspect.
Yeah.
So for the diagonal branch, if you did the pre-dilatation before you start, maybe if you have a dissection, you have to implant the stent first in the diagonal branch. And if you leave it for the end, if you is it less than 2.5 millimeter side branch, I think you do stenting the main branch vessel and reevaluate the diagonal branch. Maybe you can use drug-eluting balloon only for this.
Yeah, but the only difficulty, if you start with the main vessel, then the strategies are a little bit limited rather than if you start with the side branch and this very narrow angle. And so this is an issue also that important.
Yes, you are.
Otherwise, you think of reverse DE crash or something if you need it. But I'm sure that this diagonal cannot be left like this because it's a tight lesion extending from the proximal to the ostium.
Co-dilated.
Yeah. So Hussein is going to dilate the ostium of the diagonal branch, and then we'll go with the professional stenting to the main branch, and then decide what to do with the diagonal. Of course, we're going to take some images with the OCT and then show you.
Yeah, okay, we agree. What is the wire you are using in this?
We're using workhorse wires, so we have MW wire in the diagonal, and the Xeon blue wire in the LAD.
And this catheter, guiding catheter, is it 6 or 7 French?
It's a 6 French XD30 guide. Okay, so that's it.
Okay.
Okay. Yeah, go up. Just below nominal.
Can we ask the panel a question if somebody has experience about the using drug-eluting or DCBs on a side branch?
It's tight.
Yeah, we are having much enthusiasm with DCB lately, and this may make life a little bit easier.
Proceed now.
It's slippery.
Yeah.
Advance a little bit.
But only if you can dilate adequately
Not slowly.
the side branch.
Gentle.
And another question which we always debate here, do you finish with the DCB particularly because the company, B. Brown, basically are claiming that you can actually use the DCB and then you can do a kissing after with a regular balloon with no effect on the drug delivery.
I think there is until now, no bench testing to verify whether this can be done or not. I myself, if the lesion needs kissing at the end after using balloons, DCB and other balloons, sometimes I resort to that. I do kissing if it is essential to have a better result.
Also, B. Brown said it is the drug will dissolve or diffuse in the vessel wall within 10 seconds. That's why you can do post-dilatation after the regulating.
Yeah, it is contrary to the stent that they release the drug over a month, but
Let's make it
takes
common.
minutes.
And geographically, the diagonal looks okay for the ostium. It looks nice.
But still the size is small, yeah. So yes, I agree if you like to do a DCB for the diag and stent the main vessel, I think this could be a good idea.
You have to put a stent first, and then stent the main vessel, and then the regulating balloon for the diagonal branch. Because sometimes if you do stenting the main branch, sometimes diagonal disappeared, and you have to go again. Maybe you need a stent, but it's very difficult. Tab is difficult here. It's not the right way.
The consensus here is that we are going to take a 225 non-compliant balloon and just hit the osseum, and then followed by a DCB in the diagonal, and then we'll stent the LAD across the diagonal.
Yeah, this could be also
A good, very good option. Yes.
we agree.
Yes.
Because the diameter is much less than the LAD, so we cannot do kilowatt or maybe a second cent diagonal is not
Yes.
questionable.
Oh,
225. We have a 25.
What's not
225.
12? Okay, we'll go 12.
What type of the stent you are going to use in this case?
So we're going with a Resolute Onyx. I think we had a length around 19, so we probably need
23.
23,
22. Onyx is a 22, 24.
22 or 24.
22-24, yes. It's also the Onyx is one of the stents that becomes bigger and bigger with the after post dilatation.
So 3. Okay. So we are progressing with the 225 non-compliant balloon going into the diagonal branch, and if non-compliant balloon, and then, okay, we will keep it for 20 seconds, then down, and then we are going to use a drug-coated balloon. In this case, I think we are going to use a Paxil balloon.
Yeah, do you have, should we go with a longer drug-coated balloon since we have diffused the leads in the
225 is one.
So some may argue with you if this is the maximum
What was the pressure? Yes.
of the diagram before putting the balloon in DCB, or maybe you are afraid of overinflation to have dissection. So this is one of the challenges also.
What was the pressure in the diagonal branch? The pressure? Nominal.
We just went to nominal pressures.
Yes.
We just went to a nominal pressure with an NC balloon 225, and on the initial angio that's not saved, it looks actually very nice. So we're going to take a bit long drug-coated balloon here just to treat as well the proximal segment, and then we'll go with the stenting to the main branch, and then we'll take OCT, and hopefully everything will be fine.
Yeah.
While Dr. Attire is ballooning with DCB to the diagonal, I don't know if you want to discuss that in this case or not. There's always a debate about how complex is the side branch. And in this case was basically a common case that we see every day in our practice. It's not that big, it's not more, it's less than 2.5, but yes, we have some disease in the proximal and fifth segment. The diagonal is hugely diseased. There was a nice discussion at the beginning whether to go two-stent strategy up front or not. I think it was a borderline for either way. And based on what we have seen and the behavior from the diagonal branch at this point, I think going with a professional stenting with PCB to the diagonal is a good strategy here, and we'll evaluate further.
Yeah.
This is 2.5 DCB.
Yes, paclitaxel 8 is a 2 to 5. 2 to 5, 8 atmosphere is a nominal.
Oh, yeah.
And so at the end, you may need kissing, or it depends on the angiographic view, angiographic.
Okay, do twice after 30 seconds down.
Down.
Leave it breathing a little bit, pull back half millimeter.
How long you inflate the balloon? Is it 1 minute or 45 seconds?
Well, he was feeling, the patient was feeling the pressure.
Pain? Yes.
So we need 30 seconds, then we're going to do the second time, 30 seconds possibly. So I think that at least we wanted to get 1 minute done, but we wanted to have the patient breathing a little bit in terms of pressure. And so we pull back gently the drug-coated balloon, and we are advancing now that the pressure is much better, because we are going to occlude a little bit also the NAD, so the pressure is, it was going down to 80, and so we wanted to just to leave the patient breathing a little bit. Okay?
The old people like me who used to use the DEP, it was recommended to be about 45 seconds or 30 seconds to 60 seconds. With the DCB, nowadays they are recommending even 20 seconds is more than enough for drug therapy in these cases. We usually, what we do here, trying to aim 1 minute, however, if there's lots of chest pain or any hemodynamic compromise, or like in this case, we are including both LAD and diagonal.
No.
Sometimes we do it 2 sticks, sometimes we are satisfied with 50
Okay, we need to go with the 22. If it is Medtronic, there is no 24. This is Is that the limit? This time. Any question from Tana?
Yeah, can you show us the result after using after the DCB?
Okay, we'll give you an angio right away.
Yeah, it looks much better.
Okay.
ACT, heparin.
Can we check ACT again?
Yeah.
Can we give
We are going to go with the stent, and we have taken a 3/0 by
25 fentanyl?
Can you place
resolute on it.
We see something like haziness in the LAD. Do you think there is some vulnerable plaque there?
Yes. Looks like there is a dissection there.
Yes.
So I think we just need to act quick and go ahead and stent it.
There's maybe a little dissection in
We
the.
checked our ACT. Our initial ACT was above range. So we just need to act quick. Okay, can we have a 3/0?
Yes, 22.
22.
So the diagonal looks better now, and now you focus on the LED.
Yes.
They have your sequence of visualization. Okay. Can you also see the live?
We adjust our camera so that you can see the OCT.
Live?
Yeah, not yet. Not yet.
So you can see the live angio that is in parallel to what the operator is doing with the reference.
Okay.
So be very careful in placing, and we are checking also in the RAO projection, the proximal.
Okay.
If you are going to the RAO, we wanted to be sure.
What are we?
Change code a little bit, the ones, okay?
That's it.
We are doing a small check to see, seems to be okay. Let's go to epicranial, and then we will, in the same projection, and then we will implant another check.
That's it. Okay, we're good. A bigger
Check.
test. Bigger test.
Okay, I think we can, don't move back, go.
Go on.
Back little bit, yeah, maybe.
Well, I think that we are back.
Yeah, go.
We went back, go.
Go.
Do you like to have other? Yeah, it looks
Okay.
fine.
Well, down.
What was the pressure?
We went up to normal. Patient is feeling the chest pain, so we just we'll give him a breather.
go on to full screen.
But are you far from the left main? I mean, if you have time, you could have checked also in other view to see how, if you are stopping at the ostium of the LED or earlier. Yeah.
Looks nice results.
Looks fine.
Okay, give another 25. please.
Okay, pressure is okay. We are going now to get small cine.
Yeah.
And then we are going to post-deal the stents. We wanted to have a look to the patency of the diagonal branch. Okay, we needed to recross, of course, possibly the diagonal. We wanted to, but before we are post-dilation of the stent. Can you see that in fact this study, somebody was questioning about the measurements. We are already 1.05 to 1. So we are already at the limit
Yes.
of this pressure. Now we are going to get the post-dilation with 3.5 that we are going to also in the proximal part, and then open up in the cells and then leave in the wire, and we are trying to recross in diagonal branch.
Yes.
And then please discuss a little bit on these results that you would like to do.
So you will remove the wire of the egg or you use a third wire?
You could do potentially a wire switch. We'll just try and switch the wires after we do the part.
But I will pull back a little bit the wire from the distal diagonal, just to have a less space.
This is a nice point to discuss our panel here. There are many techniques. None of them is perfect. Each one of them has advantage and disadvantage as well.
Okay. Okay.
I myself tend to leave the wire and get a new wire, or sometimes I pull back the wire and the LED in the main branch just to, because I'm 100% sure I'm inside the stent, and rewire the side branch using the main wire from the main branch, and pull back the wire. Leaving the wire in the diagonal and using a different wire or the main branch wire will always give you more or less guidance where to enter the side branch, and it makes your life a little bit easier. Maybe some other expert people, they will do that. They just pull the wire and
you see that the flow in the diagonal is actually TIMI3 flow. So it's not mandatory to do something in the diagonal. Sometimes after removal of the wire, the flow even becomes better, and this pinching you see sometimes disappear if you remove the wire from the diagonal. You don't need to do anything more. So I prefer to remove the wire from the diagonal and to see what's happening. Probably I can see good results after this.
And the clear stent.
Okay. Okay.
But we agreed that we
Ario,
use a new wire, because this wire from the egg, if you remove it, it had already been changed after putting distally in the egg.
Okay.
Pull back one more.
Yeah.
Okay.
Clear stent.
Keep this one, clear stent.
Okay. Ready?
So this is like a pot or just post-dilatation?
This is the actual part.
Yeah. What is kind of balloon and pressure you
Go is perfect. Dilated. Go.
So we did post-dilated the most, just before the distal end of the stent.
Okay.
And he's potting with the same balloon as well. It's a short balloon, and we have a good distance between the diagonal and the proximal end of the
same
stent.
projection.
And June,
Sorry?
Yes, but now
okay, that's it.
the diagonal with another wire. Do you have a Sion?
No. Do you want the third wire? We can use it.
I would remove the wire and put
Okay.
cross.
Okay.
You have a dissection inside. So I will leave the wire and use another wire.
Okay. Okay.
There's also some dissection proximal.
Can I?
So let's take in. Okay, Cine is coming.
That's good.
I think the results in the main vessel is good. There is a little bit of a constriction opposite of flow divider. Then we will see a little bit enhancing, but now the major intention is to go into the diagonal, and we prefer to add one additional wire instead of removal because there is a little bit of dissection. Dr. Nagy.
Yes.
Yeah.
So maybe you can't see it very well on the images here, but there's a question about maybe a dissection or might be related to the wire. I think the osteum remained to be okay. The flow remained to be okay. He had no chest pain, no changes in our ECG. We will rewire the diagonal, leaving the first wire as a state.
Yeah.
It's a true dissection that we need to deal with. And we'll take, after that, hopefully we'll be able to quickly do an OCT and show you on time. How many minutes we have for?
Yes, still you have time. Not all the dissections need to be stented, and so maybe that's what we are going to learn from the OCT. If the Tamiflu is 3 and it's not, it's not Tamiflu limiting and not a big dissection, maybe you can leave it.
Yeah.
Or maybe a little, I don't know if you can dilate again with balloon to see the dissection with just balloon.
It's a little bit deformed, the wire. Is starting to.
Which type of wire? Is it a medium or a flop wire?
It's just a regular BMW.
BMW.
The one is better.
It's a cyan blue.
Oh, it's a cyan blue?
Yeah. If it doesn't go, we'll just go with the cyan blue.
It's starting before. Starting a little bit before. Okay. Gentle.
Take it easy.
So now you pass through.
Right branch.
Can you have a test? Because this.
Small test there?
Might be
I think this is maybe you can take it back and take it back at the point.
Yeah.
Yeah, of course there is some dissection while you are wiring. We see that you are wiring carefully because of this
Yes.
dissection.
Start from here, yeah.
Yeah.
Try to straighten it.
No, it's not.
If you have a resistance, you have to stop because maybe
No,
yes,
you
yes,
slow,
okay. Yes.
You need to gain a little bit of patience and time when you are doing these things.
Yes.
It was already dilated.
It's very
and,
nice.
Now it's in position, and so always we need a little bit of patience before going in rush. And now we are removing the other wire, and then do what? Doing kissing, not doing kissing. What about the possible malposition on the opposite side of the main branch? Because we have already dilated. We wanted to get some feedback from the panel in this case. We're going to use a small balloon in the diagonal branch. What about the strategy in the main branch? Now just keep watching on the guiding catheter because it's such inside during the pullback of the wire, the ones that was jailed.
I think if first you withdraw the old wire, and then if you are sure there is dissection, and you do you want to do prolonged inflation at a low pressure, and then assess.
Okay, balloon 2.0, new balloon.
Yes, you take a point 20 balloon on the side.
15.
20 to cross the struts.
Okay, we are following your instruction. The 20 balloon is coming.
Yeah. Do you like to have other view to make sure that the section and if it is just small one or it is extending?
Okay, we want also to save a little bit the contrast we are using for OCT. I think that is a relevant point addressed, but now we would like just to try to get this balloon inside to see if we can go in, and then perhaps you can help us on the strategy. Do you want to do a kissing? You don't want to do a kissing in this case if the balloon is crossing?
I think the ostium of the diagonal, whatever we did, is not very much covered, and so kissing is. I think it's important to do. Yeah, because it's like you read pot, and then it's like the old provision that you do pot kiss pot.
Why has this pain on the femoral? Possibly we need some anesthetic on the femoral.
Okay, go.
Okay.
Let me know as well.
So,
So the balloon was crossing.
Yes.
Now you can see.
okay,
So
down.
how many are
No.
Then we are going to take a small view. Perhaps we can change the scene now.
Okay.
People wanted to see a different view, cranial, a little bit, so we don't have too much time. And then we will see also in this view. We can take a
Yes.
scene in this view.
We have about 13 minutes left, so
Yeah.
Okay, should we do the OCT?
I think that we can do the OCT in the main vessel. If you agree, going back to the AP cranium.
Yes.
Yeah.
And make available the OCT here.
If you have a good results in the main vessel, there is no need to do a kissing at the end, which is for this case.
Correct.
Yes.
Correct. But we will confirm it with the OCT.
I need the OCT.
Yes. Turn the camera to this side of the screen.
Jesus. The same that we had before.
And speaking about the dissection, it is not flow limiting, and I think it's limited, very limited.
Okay, fine.
4 to 6. Okay, we are just entering the catheter, wiring the OCT catheter. The main operator will advance, and then in a couple of minutes we should have on the LED. We are helping in the door closer.
Okay, I got those wires.
So the diagonal is still patent. The ostomy is always. Let's try to advance the catheter. So the first hip is. And
Come closer, please.
go in. So go.
Sorry, come on. I think I need the, sorry, what's going on? Okay.
Patient is with a bit, let's try to go. Advance the catheter, please.
So can you explain to us what we are seeing, the OCT?
No, advance,
Trying to advance the
advance.
OCT catheter, but the patient is a bit moving, so we're just readjusting.
Advance again.
1 second and we will be.
Advance, a couple of millimeters more, stop.
Okay.
This way.
Do you see the OCT screen?
Okay.
Yeah, now we can see. Yeah,
Okay,
screen.
yes.
Yes.
Okay, now we are checking the quality of the injection. 1 second. Can you see that is crucial, is what we call path switching. Okay, and we are ready to begin the sequence of. Okay, see. Done.
So how
Okay.
does the stent look like?
It took just a couple of seconds to remove this one. Now in this couple of seconds is telling you what to do. We are accepting the pullback. Why is not doing? And then we are fixing from the proximal to the distal. And then he is confirming the co-registration. He is here you have the essence. So number one, we are going back. We are going back to this longitudinal view. Here you have the structure. Here is the entrance. You can see the first that we are controlling is the exit. And the exit is showing that there is no dissection at all. Can you see the OCT?
Yes, it's clear. It's very nice.
Okay, so the first to check is the exit, the distal edge. You can see that we respect entirely the size, we maximize the size without any type of problems. Then we are going back. All the struts are very well opposed. Can you see the automatic detection?
Yes.
There is no evidence of malposition. Then we are going proximally. We are just going this way and do the sizing. Here you can see that this is the entrance of the ostial of the RAD, then the stent proximally, and I have a look to the lumen area. In mid panel you have 80.4. And then this is the proximal part. We achieve a very nice lumen with all the apposition. Then we are going here where is the branch. Here you can see that there is the pink dot. Upward, you can see the wire going into the diagonal at noon.
Yes, it's clear, yes.
It's widely open, so we will leave in this way, and then we are going distally to check again. So in terms of review, you can get also the expansion that you can see is very good. Is everywhere more than 100%. So I think that we are going to get one last angiographic and we achieve the best possible, in my view, based upon the imaging guidance in this complex lesion. Can we have a couple of angiographic view here and comments from the panel?
It is
So
a very...
these are perfect results, and it was imaging guided using the OCT. And as I mentioned before, that this coincides with the October study showing the bifurcation using the OCT
Wire out from the
superior
diagonal.
to angiographic assessments.
Both the back
And treatment of the diagram, we agree that only drug alone was enough to fix the lesion.
You want to take in the LAO view?
one and one.
LAO view?
This one and then the other.
Now we have So now we welcome Professor Wael Kashkari, who arranged this session and this joint collaboration between CSS and Egypt Society. They did a perfect case. It was LAD and diagonal, and it was OCT guided, and they ended up by DCB to the diagonal because it's small and the narrow angle, and still take
That's
the
correct.
LAD, and now we are showing a perfect result for in the LAD.
And then geographically, it looks a nice results also.
Neutral, 0, 0.
You will do the right in another session, the right coronary.
We will do the right coronary later on in another session.
Go and check. Go.
Do we have a minute to go or?
Keep
Dr. Naji and Dr. Hussein, really thank you very much for
This way.
the great result and great contribution of Saud Al-Batain Cardiac Center at Dammam. We are very proud of you guys.
Thank you
Thank you
very much.
everybody. Thank you for CardioEgypt. Just one thing more. Dr. Hamid Al-Ghandi was supposed to be with us today. Unfortunately, because of unforeseen reason, he wasn't here with us today.
Yeah, show me your face.
Okay. Thank you, everybody.
Thank you so much.
Put the camera on the operator, guys.
Thank you very much, and welcome you. And the next year you will be with us, inshallah.
Thank you very much, and welcome always to CardioEgypt and the Egyptian Work Group Intervention, and see you in all our meetings.
Thank you.
Okay.
I did a tweet a few days ago. I said the Egyptian Cardiology Society, this 51 meeting, 51 year of doing this great meeting. This means they start before I born. Really, it's a legendary story, and we are very proud as a SASIS, Saudi Arabian Intervention Society, to contribute to this great meeting. Thank you very much.
Thank you very much.
Welcome.
Now.